And we're coming together as a network, as a community of practice, to understand more of the context, but also to be able to see if we can find ways to move together, to solve some of the challenges, to answer some of the questions, to listen to some of the experiences, and in the end of the day, to make a difference in that compassionate space where we know so many people are finding themselves. So without further introduction, I would actually like to invite our first speaker. Joan Marston asked me to introduce herself as a palliative care nurse specialist with 33 years experience. I'm handing over to her now, and she's going to introduce the whole topic of why we're here today. Thank you so much, Joan.
I wonder how many of you were like me. Even though I'd worked through the HIV and AIDS pandemic in the 80s and 90s, somehow or other, humanitarian crises were something that was over there. It wasn't something that really affected me. It was something you saw on television, you saw on the news, and you thought, wouldn't it be amazing to go and work there? But it really didn't touch me. And when I first started looking at the Syrian refugees in crossing all those borders, coming out of Syria in such huge numbers, I really started thinking about, but maybe it isn't just so far over there. Maybe it is much closer to where we are. And it really is with the COVID pandemic, with the rise in things like violence and crime, that made us realize that actually humanitarian crises weren't that far away. They were within our own countries, within our own district, and we're really only each of us a hair's breadth away from a humanitarian crisis. And so it's no longer anything that's over there. And we join together, as Moira said, both humanitarianism and palliative care meet in this common goal. We both are looking at how do we prevent and relieve suffering. But I was asked to talk about assessing the need for palliative care in humanitarian crises. And the need is both numbers and it is individual, it is human. If we look at figures that have come out from, first of all, the International Rescue Committee, where when they looked at just 10 countries that are on the international watch list for 2021, and of course it includes Afghanistan and Yemen and DRC and countries that we know where there are horrific needs, that's already 124, nearly 125 million people in need of humanitarian aid. And the ones that we look at very closely, of course, are those who are displaced. So of 80 million people who are displaced, 86% of them are in developing countries, where resources are low, where health systems are fragile, where often the political systems are changing constantly, and where we often know that palliative care is either non-existent or it is only seen in certain patches. And for myself, who's very involved in pediatric palliative care, which is my passion, if we look at almost 34 million children under the age of 18, it really says to us we need to be doing more from a pediatric point of view, and pediatric palliative care has got to be an essential part of the palliative care response. Then thanks to Stephen Connor and to the Global Atlas of Palliative Care, we have an idea of how many people require palliative care every year. So that's nearly 57 million people. And again, where these people are mainly in low and middle income countries. If we look at 97% of children live in low and middle income countries, and 51% of these children are in Africa, it also says to us where we should be starting to plan as part of our strategy. But if you look at almost 50% of people who are dying who needed palliative care, are we anywhere near reaching them, even in the high resource countries? So what can palliative care offer? Of course, we know that we look at holistic care, we look at relieving suffering, serious health-related suffering through care of the body, mind, and spirit. And yes, that is so needed. We also know it's a human right, and human rights are not only in our countries, human rights are right there in the midst of a humanitarian crisis as well. How do we get it there? And thank you, Frank Brennan. And if we look at universal health coverage as being part of the aim of the World Health Organization, of SDG 3, the health SDG, it is an ethical responsibility to provide palliative care as part of universal health coverage. So all of these are an indication of the need for palliative care in humanitarian areas. And so really, universal health coverage is not universal if it doesn't reach into refugee camps, into where migrants are gathering, into humanitarian crisis situation. Our challenge is to get it there. And we know that health coverage is not complete without palliative care. So again, the two of them coming together. And from WHO, when they spoke about COVID, they said both palliative care and a humanitarian response are needed in the world's response to COVID. Later on, Tamsin is going to be speaking to you about Cox's Bazar, so I'm not going to go into any detail, but that wonderful rapid review that was done there by Megan and Fazana and with Palchase involved shows us that the numbers, yes, are there, but also it's the need of each and every individual. And I think that is what calls to our humanity, not only as people, but as palliative care practitioners as well. We have to remember, it doesn't matter about the numbers, we have got to reach each person. And these people are like us. All of us could be caught up into naturally occurring hazards. And so the impact of climate change on both palliative care and humanitarian responses is going to be huge. All of these things could happen to us: extreme temperatures, storms, floods, epidemics. We're all in the middle of the COVID pandemic. And of course, really, we look at the man-made hazards. How can we control those? How can we get into these often really dangerous environments to provide palliative care? And of course, the main way is to integrate with other organizations that are part of the humanitarian health response. And so the question that Larry Beresford asked in his wonderful article is, what is and what could be our palliative care's role in humanitarian crises? We know that compassion is just so essential in all that we do. We know that palliative care can be incredibly innovative and getting into really difficult areas. It can help in guiding those difficult ethical decisions where so often resources are limited. Who receives the care? And of course, where triage is so important, palliative care, we have shown, can be integrated into each of the levels of triage. All of these really core principles of palliative care. We often have to go down to the absolute core of palliative care and try to do the simple things to make a difference. And then the staff support, the education and the mentoring, a huge challenge to us. But we're not going into it without resources. We're not going into it unarmed as it is. We have the WHO guide, which is really free to download from the World Health Organization website. And that is a very comprehensive guide that can help us, which includes an essential package of palliative care. Then that wonderful field manual, and thank you to Elisha and to Marcia, the editors, and so many who contributed, and especially to Oxford University Press, which has given it to us free and online. And then, of course, when we had that series of briefing notes and webinars, we had one specifically for palliative care in refugee camps and humanitarian crises. And this can be downloaded from WHPCA and from IAHPC. And then we do have examples. So we're not starting from zero. In many, many countries in the world, from what is happening in Bangladesh that you're going to hear more about, to the war zones in Ukraine, to the borders of India and Nepal, we are seeing people providing palliative care. And so, of course, we know that there are things that we can copy and adapt and change when we look at providing palliative care in humanitarian crises. And we have various networks that are developing around the world, looking at this as almost a new field in the world of palliative care. So if you can join one of these networks, you can become part of the answer to the question about how we provide palliative care in humanitarian crises. And so wherever there are humanitarian crises where people are involved, palliative care is a humanitarian imperative. And so I think we are challenged. We are challenged to see what can we do, how do we do it, and how quickly can we do it.
Thank you, Joan. That was a fantastic start. You set the scene. Those of you who joined just a little bit late, if you missed some of that talk, please go back and listen to the recording, because what Joan has done is set the scene for us beautifully as to why we're here, why we from the humanitarian settings, from palliative care settings, are actually coming together to say, not that this is brand new. We have examples of people doing fantastic things in different parts of the world, but we need to be networked, we need to be coordinated, we need to be working together to address this quite significant challenge that is often overlooked. For those of you who are joining just now, I'm going to give a couple more words of introduction before we move to our second speaker. So we're in the middle of the first part of our webinar. We've got 3 speakers, 2 more to go. We're recording this webinar. We're staying in this format so we can interact and talk with one another, but not during the speakers, if you don't mind. Keep your microphone muted. We will be having a second half after the first hour, which is inviting you to be much more involved with what the network is doing and how you can get involved. But without further ado, I would like to invite our second speaker. Thank you to Kathryn Richardson. She asked me to introduce herself as a palliative care specialist working predominantly in the humanitarian sector. Quite an unusual mix. Kathryn's on our executive, and we're delighted that she's going to address us now.
Thank you, Moira. So my name's Kathryn. I'm a palliative care specialist, and I want to share with you today 3 short stories from my experience working in the humanitarian sector early in my career, and some insights as working as a palliative care specialist within the humanitarian sector. So I started working with MSF 12 years ago, and my first posting was to Bangladesh to work in a primary health clinic with an inpatient paediatric unit within the refugee camp for forcibly displaced Myanmar nationals. Severely malnourished children would be admitted daily to our inpatient unit with severe infections, usually with pneumonia or acute watery diarrhea. They would be given F75 therapeutic milk and antibiotics, and when their infection had improved, their care would be transferred to a nutrition NGO whose centre was next to ours, and the child would continue in the nutrition programme. Once the child's malnutrition was classified as moderate rather than severe, the child would be discharged back to their home in the camp and continue with supplementary feeding with Plumpy Nut. Several weeks later, the same child would be readmitted to our inpatient unit, again with severe malnutrition and severe infection. It turned out the Plumpy Nut had been shared with the other 12 hungry siblings in the home, and the child was again very sick. And this vicious cycle of severe malnutrition and severe infection we saw in so many of the children who were admitted to our clinic. And I remember feeling powerless to make a difference. But I also had the realization that the most important work we were doing in Bangladesh was to be there, to bear witness, to show that child and family that they matter, that they were not being abandoned. So there are common principles shared by palliative care and humanitarianism. Both share a similar ethical framework, and both engage people with a similar drive to respond with humanity and compassion to relieve human suffering. Both are interested in maintaining dignity, in helping the most vulnerable, and being there for people through difficult times. And this overlap of goals and ethics represents a great opportunity for integrating palliative care into humanitarian response. I later worked in DR Congo. Patients would present with advanced disease. I remember one man presented with a large head and neck tumour at the site of his mandible. He was severely distressed and his face displayed the agonizing pain that he was feeling at the sight of the tumor. We had little to offer, no surgery, no anti-cancer treatment. We prescribed regular tramadol and asked the man to return after 1 week. When the man returned, I barely recognized him. His face was relaxed, he was smiling, he looked peaceful. His pain had improved, and he repeatedly thanked us for helping him. So simple palliative care interventions can have a big impact for patients and families. And while we felt we had little to offer for this man with a tumour, by relieving his pain, by relieving his suffering, we had had a huge impact on his quality of life. I remember caring for a young woman with advanced HIV and TB. At the time, we were waiting to have access to antiretroviral medications in the project. There was stigma associated with HIV. The Congolese doctors asked us not to write the diagnosis HIV in the medical notes because the staff would talk and the community would find out this lady's diagnosis. This young woman was approaching death. The team and I battled on with more IV cannulas, more antibiotics, hoping to avoid death, hoping to avoid what I felt was failing her. We did not succeed. I, like so many doctors working in humanitarian response, focused on life-saving interventions, even if they had little or no hope of being effective. I did not know how else I could help. After working in the Congo, I wanted to learn better how I could respond to the suffering I had seen. I moved to London and I started training in palliative care. Within weeks, I had gained skills and knowledge which would have enabled me to respond much more effectively to this suffering. So these are my experiences, and I know they're shared by so many who are trained to save lives, but do not know how to attend to the dying and chronically sick. These are my stories, but these projects are still running more than 10 years later. And while many, many patients have had access to medical care, thanks to medical humanitarian organizations, they were not able to access palliative care. So we have a great opportunity to integrate palliative care within the medical humanitarian response. There are comprehensive medical humanitarian operations in most humanitarian crisis settings, meaning there are resources for implementing palliative care, meaning there are doctors, there are nurses, there are mental health teams, there's medication supply, and there are healthcare facilities. So medical humanitarian organizations respond to different types of crises. Epidemics, conflicts, and disaster response are all associated with high mortality. But most humanitarian response is to more protracted crises that may last for many years. In protracted crisis, the pre-crisis care for patients with life-limiting illnesses may have been interrupted, and for many patients, that care may just not have existed pre-crisis, meaning that many more people may need to access palliative care. Vertical projects may also be associated with high mortality in some settings. For example, advanced HIV, MXDR-TB, and neonatal projects may all benefit from having a component of palliative care. And we know that populations who have been forced to migrate have also been shown to have high palliative care needs. Next slide. So what might palliative care in humanitarian response look like? And as Joan says, we do have examples of people doing wonderful work already internationally. But the palliative care in humanitarian response, as I see it, needs to be simple and clearly defined so that we can reasonably expect it to be integrated within the medical response. So we can think about palliative care as having different components of care, and the medical programme can integrate different components of palliative care depending on the needs of the population being served. For example, we can think of symptom control as a component of care, and we can introduce simple assessment tools to help with symptom screening, symptom assessment and symptom management for physical and psychological symptoms that are commonly seen in patients with advanced disease. We can think about supporting patients and families through progressive illness and end of life, and think about giving teams the skills in communication, counselling, meaning emotional, social, spiritual support, and care planning to help them to do this. And we can encourage multidisciplinary team working to aid decision making and provide support to doctors who are making decisions about whether to continue active treatment and making decisions about ceilings of care. And we can encourage palliative care in parallel with active disease management, and aim to dispel the myth that palliative care is just care in the last hours and days of life. So while there are many challenges to integrating palliative care in the humanitarian sector, there is a cause for optimism. As Joan mentioned, in 2018, the WHO produced the first programmatic guidance on how to integrate palliative care and symptom relief into humanitarian crises. And in the same year, the Sphere Handbook included for the first time a chapter on palliative care. Within MSF, we've started to integrate palliative care into neonatal, advanced HIV, and NCD projects. And we've just completed the first guideline for MSF on palliative care, and we're designing some training programs in palliative care for field staff this year. Also within MSF, we've produced guidelines on symptom control and communication at end of life for field teams responding in the COVID pandemic. And I know other medical humanitarian organisations are also turning their focus to guidelines and training for their field staff. We're at the very beginning of learning how to integrate palliative care into humanitarian response. And we need to learn through research in the field how we can do this most effectively. We need advocacy to raise awareness for palliative care, and we need advocacy to improve access to immediate release oral morphine, an essential medication to providing palliative care. So in summary, we have a great opportunity to introduce palliative care into humanitarian response. Palliative care and humanitarianism share similar principles, meaning that humanitarian health workers' attitudes and hearts are focused on relieving suffering and providing compassionate care. We need a model of palliative care that is simple and clearly defined so that it can be integrated within the medical response in humanitarian crises. Palliative care in humanitarian response is in its infancy, and we have a long way to go before patients and families living through humanitarian crisis can have access to palliative care. I hope the narrative of future humanitarian healthcare workers can reflect on how they were able to help and not how they felt they failed patients and families facing chronic illness and death. Thank you.
Thank you so much. That was incredibly helpful and very clear. And I think both your own personal journey as well as those conclusions that you've given us, showing us the similarities and the opportunity. I can see some comments and questions coming through. So thank you to everybody for that. Please keep them coming. We're going to take questions and comments at the end of the three speakers. And some of you are asking about the network. That's going to be the topic of the second half of our webinar, but we will say a little bit more after our third speaker. I'm absolutely delighted to welcome Dr. Tasnim Binta Azad, who is working in Bangladesh. She's previously project coordinator, the International Organization for Migration. Now, Tasnim is going to bring us a really important perspective, and that is from working on the ground in an example of integrated care. This is something we'll do every single webinar. Tasnim, it's lovely to have you with us. and for you to be our first speaker sharing from Bangladesh. Thank you so much.
Thanks, Moira ma'am. Welcome everyone once again. Yes, this was my project, Palliative Care in Bangladesh, and this was the very first time I started working with palliative care and in Cox's Bazar. You could see, if we think about what's going on in Bangladesh, then we can think about what was happening in Cox's Bazar. And while I looked at the national data, there is estimated 600,000 patients in Bangladesh who need palliative care each year. And 200,000 patients were diagnosed with cancer. When we talk about palliative care, is coming up with cancer and other diagnoses, also terminal illnesses. And in a stage, Bangladesh is now, from the practical experience, close to 80 to 90% of cancer patients, while they are visiting the health centers, is like they are already in incurable stage. Before I started, I was lucky to get people, many of them are present in this webinar. They did some initial palliative care works in the Rohingya camp. It was done a need assessment in November 2017, right after the influx. Some of you might know that the influx was in August 2017. And after that need assessment survey, there was development of a small home-based care. And it was led by a national palliative care consultant, Dr. Farzana Khan, my mentor and my supervisor, the very first one with whom I started to know about palliative care. And only with 2 Rohingya volunteers, community health volunteers, she was doing that door-to-door visit and providing that palliative care services. And it was close to 1,000 patients that the team reached. After that, in February 2020, the IOM took over the project from Fasiuddin Khan Research Foundation. Like all other programs, we had many challenges and some of them are still ongoing. The major challenge was and still is existing, not like very strong like previous. That time we started working, it was like the understanding of healthcare professionals about why palliative care is important. Second one, we started in January 2020, and in the whole 2020, we had problems with COVID. So in-person training inside the camp during COVID was a real challenge. Use of morphine, I was hearing Dr. Kathryn's presentation that use of morphine and the controversy. Bangladesh is not beyond that, and inside the Rohingya camp, it still is difficult to think about whether we should use morphine or not, how the healthcare professionals see it to use morphine. And not the last, but a very important one, that while we worked with palliative care, it was a sense from the other healthcare professionals that one team is dedicatedly working for palliative care. So why we are not sending the patient directly to the palliative care team? And initially I was told by many professionals that this is not the place to do palliative care. Definitely this program will not get many patients. This is the data from January to September, how many patients we served by our small team. We served almost 6,000 Rohingya populations, among whom 1,000 patients was actually Bangladeshi, the host people. I often get questioned that we were working inside the Rohingya camp, and how do we get patients from the host community? And it is still unforgettable to me that I heard some comments from people that they traveled to the Rohingya camp, the Bangladeshi people, and some of them are saying that we heard there is a small team who is working with people, those who are already incurable diagnosed, and it's very harsh that we heard there is nothing can be done for us, but still one team is working here. That's how we visited, and the number is 1,000. How we identified, definitely we followed some of the guidelines and resources available online, and we got many guidance from our project lead, Dr. Farzana Khan madam. But initially what we adopted from the triage station, our nurse, the palliative care nurse, used to visit the triage station. Even the nurses who were working in triage station, we used to talk with them that if you get any patient who is having life-limiting illness, you can send the patient to us. And we started with capacity building for the healthcare professionals, and later on we were getting so many phone calls from different health professionals, and they were asking for the symptom management advices, sometime to send the patient to us, but it was always confirming before sending the patient to us, so it was kind of over confirmation. And second one, we looked at the home-based care. Our palliative care assistant used to visit door to door to see that if there is any individual who is suffering from serious illness. Before we started our field activities, we trained the whole team by both national and international palliative care experts, and we were lucky to get 2 World Cancer with us, and a few of our team members already got training from 2 World Cancer. And from that side, with ECHO programs, we got a very strong network to ask for help. And that what we have to do when we have really limited resources, and that's the very first and the only program existing in that area. What helped us? The list could be very long, but in short, definitely the capacity building training to make people understand why it is important. Another one, we looked at the community-based approaches rather than the facility-based one. And we got continuous guidance and support from our project lead, who is a national palliative care consultant, I said before. And last but not the least, very important, but we were flexible. I think the team is still flexible to adapt different situations, which made them stable. I will share one of my story. We got one patient in the Rohingya camp who came to our PSC in November 2020. And the patient was 80-year-old, elderly male, and he complained, just one complaint, that he is having difficulty in breathing. And while the triage nurse sent the patient to our room, our corner, palliative care corner, it was something that very foul smelling is coming, but we could not see anything visible. And while the nurse approached to the patient, we saw one cotton clothing over his neck region. It was tightly tied over the region. And while we opened this, we got a non-healing ulcer, very ugly looking, having excessive amount of foul smelling from it. And according to the patient, he was good 9 months ago, and suddenly he developed an ulcer over his right side of the neck, and gradually it was getting worse. And very next day, while we asked what happened, and very next the patient attendants came with the previous papers, and they were saying that we are happy someone is asking, because previous time wherever we went with this paper, it was like nothing could be done. According to our findings, we did the local examination, and we got the confirmed diagnosis was a squamous cell carcinoma according to the histopathology report. And we tried to do some medical management. That time while we got that patient, we tried to do the wound care dressing, and the pain management was also done. And for breathlessness management, we tried some positioning, as in this stage, we can't think about sending the patient or referring from the camp. So many other things was not possible. And we scheduled something initial visit. After the initial visit, we tried the follow-up visits and also the home care visit by our palliative care trainers. And other than the medical management, we shared our phone number, that patient and his family had a sense that there is something that we can try, we can call, we can communicate with them. And we make them understand what to expect according to this diagnosis, what could be done from our end, and what they will expect. And we got some comments from the patient. The way we started, we had no idea what we can do, but still there was something to offer, and we offered. And patient said thanks to us, and it was from his side. The comment was, I don't feel that much breathlessness because I'm not squeezing that cotton clothing over my neck anymore. And they got room to share their physical and emotional things without hiding themselves inside the house and not visiting the healthcare centers anymore. I would say it wasn't easy for us to think about palliative care, provide palliative care for this 900,000 Rohingya community. And in general, although we say one palliative care team, but I worked as a program manager there, and we had one medical doctor, one physiotherapist, and 4 nurses to work there. We had no idea about our job contract. During COVID, it was told that they will only look for the essential cares. And I was the only one that time went with the SPR guideline and said that according to the humanitarian context, according to the SPR guideline, palliative care is essential care. So there is no means you can stop us right now or you can keep it paused. I don't know the way we started, it is successful or not, because that could be something very relative. But for me, it was sense of purpose. End of the day, we felt like, yes, we are trying our very best to do something. I tried to make all my colleagues and healthcare professionals, and for myself also, both are important to alleviate suffering and to save lives. We can't judge one by another. And if you want to hear more about our works, we have a story from IOM, what I said and what we did as a team there. You can see the YouTube link here also.
Thank you so much, Tasnim. Thank you for sharing that incredibly moving story. I think what was coming through to me certainly was the humanity of what you're doing and the dedication. You told me before that someone says, why is a young doctor like you involved in palliative care? And we're delighted that you are, and for sharing with us. Now, we've had 3 excellent speakers, but I want to welcome to our panel 2 additional people that I mentioned at the beginning. First of all, Liz Grant, who's the director of the Global Health Academy, University of Edinburgh, and assistant principal, and is also, we're delighted that Palliative as a network has been hosted by University of Edinburgh. Liz, do you want to just greet the group while we're just getting questions coming through?
Lovely, and it is wonderful to be part of this group. Wonderful to have heard these 3 speakers actually really bringing us to the heart of some of the issues. And I'm delighted to say, as the University of Edinburgh, to be able to host Palchase and to because as a university we recognise just how important palliative care is in the global health agenda, how important palliative care is in a planetary health agenda, picking up what Joan said earlier, that so much of the work that we need to do is going to be so impacted by climate, by migration, by conflict, and how do we respond? So very much looking forward to the panel.
Thank you. And we also have in our panel Stephen Connor, Executive Director of the World Hospice and Palliative Care Alliance. Stephen, would you like to greet us?
Hi, everybody. Great to be with you. This is such an important issue for palliative care. And as Joan, I think, said, you can't have universal health coverage without including palliative care for people in humanitarian situations. WHPCA, for those of you that may not know about us that much, is an alliance also of over 350 organizations in 102 countries focused on palliative care development. We work closely with Palchase and with International Children's Palliative Care Network on these issues of access to palliative care, and also collaboratively with the International Association for Hospice and Palliative Care. The 3 international organizations work together to try to advocate for palliative care. In as was mentioned, we're using estimates of the need for palliative care. We do know that there's going to be a really significant increase in the need for palliative care in humanitarian situations in the coming years. I think we need to prepare for it. It's going to be another sort of tsunami like we've had seen with COVID-19. So anyway, good to be with you all. Happy to contribute to the conversation.
Lovely. I'm seeing some questions coming through. I'm seeing some answers being given. So do feel free. The reason for this format is to have us seeing each other. This is not an exclusive group at all. This is a chance to meet, to see each other's at least names and start to contribute. But maybe if I can just ask one of the first questions to Tasnim, our last speaker. There's a question here about what was the response like from the government doctors. I think that's a good question. How do we engage people who may not be interested in palliative care to get involved? Tasnim, you want to mention that, and as you're talking about it, obviously reflect on what some of the things you were told when you said you were doing palliative care.
Thank you. I guess I was expecting this question, because whenever we talk about something new or something that's really not integrated in our health system, we could see the opposition could be very strong. I was told that in our government Upazila health complexes, the place where I work, we don't have well facilitated secondary or tertiary level hospitals. The tertiary hospital is actually in Chittagong, which is almost 5 hours drive from Cox's Bazar. So I will talk about the Upazila health complexes. I was told by different health coordinators that nobody will accept this program, especially the government program. They are not willing to hear about something palliative care, people who are dying. We are struggling with to save lives, not dealing with the death and dying. And before I left, I did one presentation during the monthly coordination meeting inside the Upazila health complexes. That could be one day that could be a memorable day in my life, because with the name of the person, that government health officer who were opposing that project, I heard they were saying this is the spirit, the way she explained. Especially, I'm thankful to Dr. Hunter and Dr. Megan also, because I used some of their data and their presentation slides. And according to the government health officer, it was like, this is the thing we have to look as a human. We can't say that someone will die, so there is nothing to offer, we can't do anything. That's not the way. The world is changing, and we can think about integrating this one. Even one of my colleagues was present there, and the government people were really appreciating us. They were saying for having different corner for us, and if we want, we can discuss with them directly. That was from my end. So, but I will say, when there is something that you want to present, you can do it, no matter what's the situation going on in that country or that particular context. Thank you.
Thank you. Thank you so much for that. I'd like to move to Kathryn. Kathryn, there's a question here about staff turnover, particularly in humanitarian settings. And I think the person asking the question is both asking how we manage that, but also how we support staff. Kathryn, would you like to say something about that?
Thank you, Moira, and thank you, Erin, for the question. Actually, this is a problem. I'm thinking about a project in Patna in India, an MSF project. It's a vertical project of advanced HIV, and we implemented a component of palliative care at the end of 2019. And this was exactly a problem we had. At the start, the team were very motivated, and there was a lot of passion for palliative care. But as the staff turned over and people changed, and there was a high turnover, as you suggest, Owen, we found that actually, the symptom screening was done more like a tool that had to be done, but rather than it being something useful. And I think this is a challenge that we have faced and we will face, and we need to think about how we can keep the energy for palliative care, how we can keep up training for palliative care. And I think I like the comment that Rick mentioned about changing the culture and having palliative care as part of the normal medical response. And while we have a long way to do that, I think that's what we should be aiming for.
Kathryn, I've just got permission from my colleagues to extend the questioning a little bit longer. So please, if you have some other questions, write them in the chat first of all. We may have time to invite you, we may not. But I want to bring up another issue, and I've just come back from a field setting, and a lot of the challenges there was the number of priorities. So I wonder, I'm going to actually direct this question, I think, to Joan. If you were talking to someone and they were saying, why should we include palliative care when we have so many other pressing priorities? Can you just give me just a small response to that, just a short one? I know there's so much we could say.
Well, I think in that situation that it is difficult to answer, because when you're trying to save lives and that is your priority, and we're coming in and saying palliative care, palliative care actually is part of humanity. It is providing that final compassionate end of life care for some, and it's making people recognize that they are of value. I think that we are valuing people through our providing passionate care, even through those small actions where we're just sitting with them, where we're listening to them, where we're supporting the family. I think really it's about valuing people.
Thanks so much. And I'm seeing that there's some questions here about how we motivate colleagues. I would love you, if you've got some suggestions for that, would you pop them in the chat? So we're talking about how do we motivate government workers? How do we encourage our the humanitarian workers I've met are often saying we know the gap. We just don't know what to do to fill the gap. I want to pick up something Tasnim said too about host and refugee communities and the importance of combining that together. I don't know whether any of our speakers would particularly like to address that question, Kathryn. I don't know, I've already asked you one. How we actually meet the needs of hosts, because this is really important. We don't want to set up two-tier systems. We don't want to also set up a feeling that in order to get care, you've got to be a refugee. Any comments from our speakers? Kathryn, do you want to just make a comment on that?
Sure, yes, thanks, Moira. So my experience is with MSF, and MSF projects are always open for everybody. And while they may be in the humanitarian crisis because the refugee population are there, the care is not limited to that population. I think about Bangladesh, the clinics are all open to the host community, and actually I'm thinking about one MSF hospital within Cox's Bazar, within the refugee camps, is actually outside of the camp for that very reason, so that the host community are very welcome to come. And we do see certainly there and in many other settings that it's not just a refugee population. The host community are using the services too.
Thanks, Kathryn. And I know in Uganda, it's actually now a requirement that any response needs to be 50-50 host and refugee in the health implementation responses. I think it started off with 30-70, and now it's become 50-50, really addressing those issues. And I know we have Vicky on the call who's working in the northern parts of Uganda, and it's a really interesting question, isn't it? How we can improve medical access in general that will benefit both. Okay, so Ruth is asking about training. I'm going to pop that to Stephen, because WHPCA have been very involved in training, also in modelling over the years. It's one of the core aims of PalChase, but do you have a comment to make to Ruth, Stephen, about the importance of training and the need for that?
Yeah, well, we've actually been trying to do some estimates of the number of people we need to train to meet the need for palliative care. It's literally millions of people, and we're just at about 12% of the need being met. We have the curricula. I think it's part of the public health model that we have the access to medicine, access to education, as well as policy and resources to implement palliative care. So the training component is the biggest component, really. In terms of just the work that needs to be done in order to establish palliative care, whether it's in humanitarian emergency settings or just in general healthcare and primary healthcare. We've been kind of almost a sort of separate specialization within healthcare, and we're trying, I think, globally to really change that around so that it becomes a normal part of the culture, if you will. That was a great word. That all primary care professionals have at least a basic training in palliative care. That was called for in the palliative care resolution at the World Health Assembly. But it is multi-layered. It's primary care, it's secondary and tertiary care needs. We think, based on mostly on high-income country models, unfortunately, that the majority of people can be cared for by their primary care practitioners if they're not complex, if they don't have complex issues. And so that's why it's so important to get every country to agree to include palliative care in the curricula for medical schools, nursing colleges, mental health training, and university, and chaplaincy as well. So I don't know. I mean, it's a pretty all over the map answer to your question, but it's really an issue of political will in most countries that has to be there in order for, and you know, to some extent in, you know, medical colleges, I mean, the faculty have to accept that. It goes to that question about how do you change these sort of attitudes. And we think that palliative care is the model for care for the healthcare system of the future, particularly for people with non-communicable diseases. And we got to stop thinking about it as, you know, about people terminally ill or at the end of life. It's really, as reframed with the Lancet Commission, about relief of health-related suffering, serious health-related suffering. And there's, you know, that is independent of prognosis and lifespan, but it's really about how people with serious illness need to be cared for future going forward in general, and that we really have the model that is ideal for that.
I think what we're talking about here is integrating it into usual practice. I think that's another important question. Our time is beginning to run out, but I think what we're trying to say here is that the models, which I think I'm going to tell you in a moment, our next webinar, but we'll be particularly looking at this, is to integrate. So it's taking those existing healthcare staff, maybe also mobilizing communities and actually empowering and working together to find out what the priorities are there, to put some of these issues and skills and knowledge and values into the overall response, as well as perhaps some training at secondary and tertiary levels for referral pathways to make sure people are picked up, and making sure that's holistic. It's not just the physical, but we're looking at the psychological, the social, and Rick, you'll be glad to say I'm mentioning the spiritual, because often missed out, isn't it? And sometimes missed out because we just don't know how to approach it. So really, really important. And I thank you too for the comment that says this is actually part of global health. So that brings me, I think, to the last person I'm going to ask to comment. Liz, we're putting this in the context of planetary health, of global health. We're also, and I want to come back to that last word on Kathryn's slide, but it came through everyone's slide, compassion. So how do we look at this concept of compassion? What does that look like when we're looking at palliative care in humanitarian settings, Liz?
Oh, thank you for that question. And you're right. I think palliative care as a form of care personalizes, encapsulates what compassion is. And compassion, the way I'm using that word, is being able to notice suffering, being able to sort of identify it, recognize the part that all of us almost play in suffering, you know, reacting, recognizing that suffering is the way all of us experience pain. And suffering, many people are in the most horrendous pain. That is how they're experiencing their illness. And finally, action. And those four parts to compassion are absolutely essential. And they've been very much integrated into a lot of WHO's work on the quality of healthcare services, because as Sham Syed, the leader of the quality group, says, unless you have a compassionate approach to healthcare, unless healthcare workers understand the value of compassion, unless the culture is compassionate, then it's very hard to achieve the quality in healthcare. And Moira, you asked that question in the context also of the wider concepts of global health, planetary health, and what a number of comments have said, and it's come through in this, what the speakers have said, is that we need to rethink the whole way, our whole vision of global health anyway. There's been a tremendous shift, a very needed shift, moving from this sense that somehow the rich West and North is doing things to the poor South and East, and that whole mentality needs to be moved, and it is being moved. And I think PalChases and many alliances and organisations are really saying this is about connectivity together. It's connectivity and collaboration and curating what we have together, not setting up divisions and not setting up processes that are going to be inequitable. But it's also recognizing in planetary health that human health is only one part of the equation, and that we, in palliative care, as we care for a person, we're also caring for the family. We're recognizing the cost of care to that family. We're recognizing the family if they can't, if they're struggling to have food, if there's issues around the complex situation they're living in, that's going to so negatively impact on everyone. So compassion is a fundamental part of palliative care, but also palliative care embodies compassion. Palliative care workers have actually demonstrated, I think, to many health workers and to the health system, this is what it looks like to care completely, holistically.
Thanks so much. Thank you. I can see other questions coming in. I'm delighted there's been so much discussion there. Liz, you just summarised that beautifully. We will be addressing models of integration. So that leads me very nicely to my last task for this webinar, and that was to let you know that the next webinar will look at lessons from the field and how to integrate. Erin will pick up a bit more on the models. Many of the models that we're seeing in practice are not high cost. They do have some costs. There are minimum care packages, but much of it is an integrated model and a mobilisation model that we're looking at. I've seen some really important issues too about continuity of care or referral pathways, very, very important. And we'll be sharing some models from that in our next webinar. We're also going to invite you to join us for the second half. So in a moment, there'll be a link for those of you who aren't staying to fill in something about your experience of this webinar, but also ways in which you might want to be involved. PalChase is a network. We're going to tell you more, but for those of you who can't stay, it's looking at advocacy and education and training and how we build a network, and supporting and modelling examples of good practice, perhaps working on ways in which we can either measure evidence or look at developing some simple programs and guidelines. We really would like a wide involvement, and that's why the second half is going to be only looking at that. We're going to present some of the way where we've got to now, some of the direction we hope to be going in, and we want your input and your ideas. So please do share. If you can't share, click on that link. If you can't stay, click on that link. Tell us how if your feedback, and there'll be an opportunity to say areas of work that you might be interested in and to share something of your expertise in those areas. And I'm hoping that a lot of you will be able to stay on and have a more informal second hour where we'll be chatting and sharing, and we might even go into groups depending on how the time goes to discuss a little more fully. Thank you to Joan for reminding me very nicely there that we want to appreciate all of those who've led us this point. We'll tell you more in the next session, but there's so many people that have been involved in the development of the PalChase network, some of whom are here today, some of whom aren't. There's so many people who've done some of the really preliminary and important research, and those who've also are pioneers in their own setting, developing models. So we're very grateful to all of them. Some of them have even served on our executive, which the executive came about from an open meeting that people had some time back. So please click on that link. Stay with us. I'm going to give you just a few minutes for those of you who'd like to just take a little personal break, get a glass of water, come back with some energy for our second hour, where we'll be presenting the work of PalChase to date and then inviting discussion and feedback. Thank you to everyone. Thank you particularly to our three speakers. Thank you to our three speakers, to Joan, to Kathryn, to Tasnim, for giving us a brilliant start to this webinar series.